Welcome to Issues. We're so pleased to have you with us this evening. For the first part of our program, we're going to be looking at dental bridges. What is it all about? By the way, we would welcome your comments, and we ask you to email your comments to issuesbda@yahoo.com. Once again, it's issuesbda@yahoo.com. This evening, we have with us my dentist, Dr. Carl MacKenzi. By the way, his office is in the Arches if you want to go. Welcome, Carl. Happy to have you with us. Could you please tell us, what are dental bridges?
Well, basically, a dental bridge is a dental restoration or device used to replace a missing tooth in the mouth. And there's three types. It's a conventional bridge, a cantilever bridge, or a resin bonded bridges. And but most of the time we use the conventional bridge.
Okay. Now, bridge and dentures, are those the same terms, or are they different things?
Well, actually, a bridge is a fixed denture per se. A removable denture is something that you take in and out of the mouth. For instance, a full denture, replacing all the missing teeth, or a partial denture, replacing some of the missing teeth around the mouth. But a fixed denture or a dental bridge actually stays in the mouth when it's completed and it doesn't come out.
So then the difference, dentures come out, but bridges are fixed, they don't come out.
Yeah, fixed. It's fixed.
How does what are they anchored to? How does the dentist,
usually the bridges are anchored to the adjacent teeth next to the missing spaces. Now, I mentioned the cantilever bridge. That is where it's anchored just on one side and not on the other. So the missing tooth would be by itself and then connected to the adjacent tooth, but not connected on the other side as a conventional bridge would be. What
would keep it from coming out?
Well, from the root crown ratio, you diagnose that it would be able to be kept in by connecting it to the one side and have enough leverage that it won't rock.
Yeah. Okay. Now, in terms of bridges, now, is coloration a consideration in terms of coloring the bridge to make sure that it is the same color as the rest of your teeth?
Oh, yes. During the preliminary stages when we analyze the teeth in the beginning, we take a color shade to try to match the shade to the teeth that you have in your mouth, so there won't be any discrepancy between the bridge and the color of your original teeth. And also during the examination, we check the adjacent teeth and all the teeth in the mouth to see that it's in generally good health, that you can support such structures in the mouth.
Now, getting bridges, is that a common thing? Is that a routine procedure, or is it unusual? Out of 50 people, probably how many of those people would be coming to you for dental bridges?
Well, it depends. Nowadays, it's leaning away from bridges a lot and leaning toward implants, where they implant the teeth directly into the missing space without touching the adjacent teeth. So they're leaning more to that way. But what the drawback in that is sometimes the expense. And expense always plays an issue on the type of restorations that a person gets. So the most inexpensive would be something that's removable, and then something maybe conventional like a bridge would be something median range, and then an implant would be a higher cost.
Let's just touch on implant for a bit. My research didn't bring that out to me, so I'm quite interested in implant. What they actually, as a surgeon, you have to go into the gum and put the teeth. That seems to be more painful than the bridge.
Well, It can be in certain stages, but I mean, not always. I mean, you have anesthetic when they're doing the procedure. It's just, it takes a lot longer to complete the procedure because you have to wait on the healing process of the initial stage of the implant. So it is quite more evasive than it is a conventional bridge.
What would be the advantage of the implant over the bridge?
Well, the advantage of implants over bridges is that you don't have to do any restorations on the adjacent teeth, so they can stay virgin teeth, and so all your concentration is on the missing tooth.
Oh,
yeah.
Okay. Now, once the bridge work is finished, how soon after that can you actually start chewing, and how soon after that are your teeth functionable?
Well, pretty much right away. But yeah, I usually ask my patients to wait till the anesthetic wears off before they start really, you know, chewing or eating on it. But usually it's right away that you can use it.
Now, bridges, are they made here in Bermuda, or do you have to send away to have it made?
Well, in our office, we send them away to get them completed. But there are labs here that are going to be making bridges, or if they are not already, that they are going to be making them.
Oh, very, very good.
Yeah.
Let's move away from bridges a little bit and look at some preventive dentistry. In terms of cleaning, how often should one get their teeth cleaned?
Well, the routine is twice a year. Come to your dentist every 6 months and get a exam and cleaning. But sometimes it's not necessary for a person to come in every 6 months. Some people that have really good hygiene, we ask them if you only can come in once a year, and that's good. And then other times when it's on the other side of the spectrum, we ask them to come more than twice a year. So it depends on the individual case, but routinely it's twice a year, every 6 months for exam and x-rays.
Now, flossing, how essential is that in terms of caring for the teeth and the gum?
Well, we recommend that you floss every day between your teeth. And but speaking of flossing, when you get a bridge, there's certain type of floss that you have to get underneath the what they call the missing tooth or the pontic area. And but we recommend that you floss every day in order to get between the contacts between the teeth where the toothbrush does not get.
Now, without endorsing any type of toothpaste, are we supposed to look for certain type of ingredients in the toothpaste in terms of the care of our teeth, or are any of the toothpastes that's on the market beneficial, especially those people who may have sensitive teeth? Well,
pretty much all the toothpastes that are on the market, you know, are highly recommended. You know, I wouldn't prefer one over another, and it depends on the individual case. Now, there is a toothpaste called Sensodyne that sometimes we recommend on people that have sensitive teeth, and we seem to have a little success with that. And also there's various treatments that you can get at your dentist's office, like fluoride treatments, desensitizing treatments that can cut down on the sensitivity that you might have.
I mean, the toothpastes or tooth polishes that are out there that somehow supposed to whiten your teeth, are there any benefits to those things? Do they really whiten your teeth?
I haven't found too much success on the whitening part. Now, but I would recommend that you come in, if you really want to whiten your teeth, I would recommend that you come in and get it professionally whitened by a dentist with whitening trays and so forth. Now, there is a over-the-counter whitening strip called Crest whitening strips, and I've seen some, you know, pretty good results on that. But as far as the longevity of the whitening and so forth, it doesn't last as long. It's usually a professional treatment.
Now, in terms of mouthwash, Listerine, or whatever else there is out there, are there any benefit to those mouthwashes in terms of keeping your teeth healthy?
Well, yes. With the mouthwash, usually what it does is cut down on the bacteria levels in the mouth. So Listerine, as you said, there's another mouth rinse called Corsadil, which we highly recommend. That's sold over the counter, and that tends to work pretty good as far as keeping the bacteria levels down in the mouth and keeping your gums healthy.
Coming up on the final question, in terms of brushing your teeth, I guess most of us go up and down, but there's still some people that are going this way. Which is the best way?
Well, the best way I would say is to take the toothbrush and point it at like at a 45-degree angle toward your gum line, and just kind of vibrate it in motion and then come down on vibration and come around, and do that all around your mouth.
Okay. Now we have some toothbrush that vibrate. Are there any benefits to those? By the way, my wife just bought some of those, so hopefully there's some benefits to those kind of toothbrushes that vibrate.
My philosophy on the dental devices out there is whatever you can use, whatever works for you, use it. Because the more you use it, or the better. If you know how to use it correctly, it's going to benefit you, well.
Thank you so much. Today we've had Dr. Carl MacKenzi, our dentist, my dentist, and we've been talking a bit about dental bridges and about general health in terms of taking care of your teeth and your gum. So we thank you, Dr. MacKenzi, for being with us.
All right, thank you.
Welcome back to Issues. In the first half of our program, we spoke with Dr. Carl MacKenzi in terms of the care of the teeth. In the second half, we have Will Peckett with us, orthopedic surgeon. Welcome. Happy to have you with us, Will.
Thank you, Richard.
We're going to be looking at knee replacement. Now, exactly why would someone require knee replacement surgery?
Knee replacement surgery is really the last resort for someone who's got a very damaged knee. Typically, osteoarthritis is by far and away the commonest reason someone would have a knee replacement. There are rarer causes such as rheumatoid arthritis, but usually it's osteoarthritis. Primarily, it's due to just wear and tear and age. Sometimes it can be secondary to having had a major injury a few years or many years earlier, and that we call secondary osteoarthritis, as opposed to primary, where it's really a number of reasons which end up meaning that the joint is no longer functional.
Okay. You're mentioning arthritis, and somehow I associate arthritis with folks who are older. So my question, knee replacement surgery, is it usually on older folks, 50s, 60s?
It is. With the success of knee replacement, the age is gradually creeping down. Even when I was training, we tended to avoid doing knee replacements on anyone under the age of 60. The youngest person I've done a knee replacement on in Bermuda was 37, and I've done both knees on a lady who was less than 40. So the age has crept down, and it's interesting, the largest demographic increasing in having knee replacements is in the 50 to 60 age bracket. So it is creeping down, and I think that's probably, at least in part, due to our more active lifestyles. Probably also our excessive lifestyles in terms of the gradual increasing rates of obesity in society. There's a big link between that and knee replacement.
Right. I'm just going to ask you to talk to us some more about that, obesity and knee replacement.
It's clear, and particularly in females, funnily enough, there's for every 5 kilograms or 10 pounds that a lady is overweight, they double their risk of knee osteoarthritis. So if you think about it, there plenty of people are 30, 40 or 50 pounds overweight, then they're almost guaranteed to get knee arthritis at a relatively young age.
Is that because the weight of the body is too much for the knee to be carrying
I think
around?
that's right. I think there's a significant proportion of the reason as to why you get knee arthritis is wear and tear. Yeah. There are other factors as well, like previous injury, like genetics, possibly dietary things, but primarily it's wear and tear. So if your body's taking more weight through your knee, then it's likely to wear out quicker.
Wow. Now, knee replacement. What are the materials that you put in your knees? What are they made out of?
There are well over 100 different knee replacements on the market. The vast majority and most of the market leaders are very similar, and to look at you would think they were almost the same. They're really metal and plastic. They're effectively a plastic sandwich. I've got one here that I can show you. Essentially the knee replacement replaces the bony surfaces of the knee, and so it's really a surface replacement, and one surface is metal, the femoral side, and one surface is metal on the tibial side, but it has a plastic, what we call spacer. So in fact the moving part ends up being metal on plastic.
Well, that looks like a screw that I would use in my home.
I'm afraid to say this is one that I have in my office, and this is slightly out of date, Richard. I don't put screws into my knee replacements now. There are some that are cemented in and some that are not cemented in. In fact, interestingly, with relation to your last speaker, the cement we use is in fact originally dental cement, and that's called methyl methacrylate. And the majority of knee replacements put in nowadays would be cemented, but the uncementeds are certainly a proportion. And you ask what they're made of. The metal is a cobalt chrome, and the plastic is called ultra high molecular weight polyethylene. It's a type of plastic. There are others. They're much rarer, particularly types of ceramic, something called zirconium, but really the vast majority are metal on plastic, and they're cobalt chrome on high molecular polyethylene. And I think that whilst innovation is very important, the problem with innovation in joint replacement is because it's been so successful, innovation is very slow. And really, as many viewers may be aware of products being withdrawn from the market, often that's because they're shown to be not as good as what we've already got. And so in order to produce something that's good now, you have to prove that it's got really probably in excess of 90% 10-year survivorship. And therefore, it takes 10 years to prove that something's any good. So people often come into my office saying, oh, well, if I wait a couple of years, will there be something better on the market? And whilst it's possible, it's actually quite unlikely. And that's because it's so successful.
Now, the typical length of a knee replacement surgery, how long would that take?
Well, we don't race it, but usually about an hour. That's the time it takes me to do my bit. I would say from 45 to 70 minutes, usually about an hour.
Okay. Now, once you've completed the surgery and the person is out of the operating room, back up on the ward, how long before they are starting to walk again?
We like to get them walking as quickly as possible, and certainly the day after surgery, we're actually just looking at initiating a program to get people out of bed on the same day. That's called Enhanced Recovery, and that's a program that's being established, well, really supported by the Royal College of Surgeons and the British Orthopaedic Association, as well as the associations in the United States. And it's quite clear that people who get going quickly do better. They get less blood clots, less infections, they get out of hospital quicker, and they get a more satisfactory experience. You know, it's a lesser impact on them. So we're devising a number of ways, or there have been a number of ways devised to actually try and accelerate the recovery.
Same day. Wow.
So some of that depends on anesthesia, and obviously people are worried about pain, and we often numb the leg so that for the first period after the surgery the leg is not painful. Now that's very good in terms of pain relief, but if the leg is numb and the muscles are numb, then you can't walk on it. So we're planning on moving towards more local numbing agents, so you don't numb the muscles but you numb the knee joint. And this is something that we're not experimenting here. This is something that's been well tried and tested in the United States, United Kingdom, Sweden, to name a few.
Maybe I'm not answering. You mean during the operation it's just a local anesthesia?
No. Well, no. During the operation, usually people are heavily sedated.
Yes.
They would say they were asleep.
Yeah.
In fact, often it's not a full general anaesthetic, but their leg is numb, and they would say their family and friends they were asleep and they knew nothing of it.
Okay. Very good. Now, with any type of operation, there's some dangers. So what would be some dangers in terms of going through knee replacement surgery? If I was in your office and I was going to get knee replacement surgery, what are some cautions that you would tell me?
I always say to my patients that I spend 98% of my time talking about the risks and 1 or 2% of the time talking about the benefits. And you have to remember in that context that actually 98% of people have a successful operation. Having said that, there are risks, the same as with any procedure. And really the ones that I'm most concerned about are infection, blood clots in the leg. Occasionally people can have a knee replacement that's just painful, and they come into the operation for pain, and unfortunately it doesn't do what it says on the tin, and that's distressing for both the patient and the doctor. But that's very rare. And then rarer things such as chest infections and more general complications of surgery. Okay.
Now, once the operation is completed, is the knee just as good or better than before?
Unfortunately, we're not as good as the good Lord. I think that's a fair comment. That it is a replacement. It's not a brand new biological knee. But the people that need the knee replacements in general have lived on a bad knee for many years, and it's slowly deteriorated such that they've become accustomed to living on a very poor knee. And compared to that, it's night and day. And vast majority of people get a good or excellent result. As I say, I would have said that about at least 90% can expect a good or excellent result.
Very good. Now, earlier on, we talked about rheumatoid arthritis. Now, at what point would the orthopedic surgeon tell someone with arthritis, listen, it would be good if you have knee replacement?
It's based on, really, from my point of view, two things. Primarily the degree of dysfunction and pain someone's in, but also obviously making the correct diagnosis and taking x-rays and showing that the knee is advanced enough that no other lesser treatment would work. Often x-rays alone are all one needs. I think in this day and age all my patients come in asking if they need an MRI scan, and actually for advanced osteoarthritis a plain x-ray is often all you need to diagnose the condition.
Now, well, I know that you're a runner. So what damage can running do to the knee?
That's a very interesting question, and I have to say I'm not sure that science has really answered that question as far as I'm concerned, because people like me are difficult to come by in scientific groups. In other words, someone who runs hard for 4 or 5 years, then stops and puts on 15 pounds, then drops it for 2 or 3 years and then runs again. What they can get is someone who's averaged 50 miles for 15 years. Now, those groups are very healthy. They're often very skinny. They've often selected themselves for being very good runners, and so they do very well. And there's not a lot of evidence that they have excess arthritis. But for the occasional runner, I think it's probably fair to say that you are probably doing some damage. But on the other hand, you're benefiting your knee by controlling your weight and controlling the muscles around it. So on balance, I think overall it's far healthier to run and keep your weight down, and running has other health benefits as well.
Now, when one runs, the type of surface, does that do damage to the knees? Comparing the asphalt on the road, the sand on the beach, or a grassy area,
Yeah, I think again, there's intuitive evidence, but I don't think there's a lot of science to support one from the other, because quite frankly, most runners will have run on a combination of surfaces, so it's very difficult to prove. Get someone who's just run on the road for 10 years and compare him to someone who's just run on grass for 20 years. But on the whole, one has to say that choosing a firm but forgiving surface is better than asphalt. Having said that, I'm often wonder about running on the beach, where it's soft and often overly forgiving, that you may overly strain your ankles, feet or knees, and it may be harder on your joints possibly than running on a firm, grassy, smooth surface. I don't know. That's just speculation rather than scientific fact.
Now, in terms of your own practice, do you find many people, like sports medicine, are you part of that in terms of, we have football or soccer here, we have cricket? Do you see many of these people?
Very much so. That's a big part of orthopedic surgical practice, is sports injuries. And I work closely with the sports injuries doctors in Bermuda as well. But certainly sports injuries are a big part of my job, because outside of knee replacements, I do ligament reconstructions in the knee, and I do arthroscopic reconstructive shoulder work, and those are two of my biggest areas. And that's very much sport related. And yeah.
With the push now to exercise and many of us being in the gym, do you see, do you get any business from those accidents in the gym?
I think I do, and I like to see people live a healthy life, and I think we have an obesity epidemic here in Bermuda that I would like to see confronted, and certainly exercise is a part of that. But I think sometimes or it needs to be approached with caution, because one's looking at the long term. One wants lifestyle change that is meaningful, and so that people are healthy for years, not exercising vigorously for 6 weeks and then they get a pain. So I think that one needs to do it gradually and possibly under the care of a professional, so that they don't overdo it and injure themselves. That's important,
What benefits in terms of warming up before one exercises? What benefits are those?
I think there's clear evidence that warming up helps. And I think that again, that's a sensible way of approaching one's fitness, is to do a gentle warm-up, possibly with some stretching, although the evidence to support stretching per se is less clear-cut. But as part of a warm-up routine, I think it's a valuable thing.
Okay. Last question. You mentioned shoulder before, that some of your surgery is shoulder related. What type of injury, or why would one need it? Would it be arthritis? Or?
Interestingly enough, arthritis is a lot less common in the shoulder. Probably 1 in 10 people in the United States get a shoulder replacement for every 10 that get a knee or a hip replacement. So arthritis is less common, but making up for that, of course, is rotator cuff disease. From the simple, what I'd call impingement, where the bones of the shoulder rub on the rotator cuff muscle, giving inflammation and pain, and that tends to happen in the 30 to 40 age group, as opposed to tears of the rotator cuff, which tend to happen in the more 50 to 60 age group. And those can mostly be dealt with arthroscopically and very effectively.
Now, sometimes I hear people, I thought that was going to be the last question, but something came to my mind. Sometimes I hear people getting their knees cleaned out, or what is that?
That's arthroscopic surgery. And arthroscopic is essentially keyhole surgery. It's when you use a small telescope and possibly 1 or 2 little holes in the knee that maybe require 1 stitch to close. And it's a very effective way of cleaning up the knee if there's torn cartilage or irregularity, and it can be done as an outpatient. It's relatively painless and can be very effective. Unfortunately, it doesn't resurface the road, so it's not good for dealing with advanced arthritis. But for more modest problems, it can be an effective way of treating it, and a lesser treatment for arthritis or cartilage tears.
Thank you, Will. We've been talking with Dr. Will Peckett, orthopedic surgeon. We've talked about knee replacement. We've seen some of the metal and some of the plastic that goes into our knee, and it's been very interesting to have Dr. Will Peckett with us. And we look forward to seeing you on Issues next time.